So this is something I'm very passionate about. I think I've heard it be like a niche for strength coaches of return to play, and I think it's more than that. Should be a standard within our scope of practice, especially if you do it the right way. So today, I just kind of want to talk about, how to formulate a blueprint for a return to performance program, and then how to make your athletic performance program go a bit further. All right, so a little bit of my background. So my first ever internship was with the Virginia Beach Fire Department. Really interesting perspective I got from that. Got to see the wellness and recovery, different point of view, different competitive excellence, right? So theirs wasn't how many wins in a conference. It wasn't how did you win the state championship. It was longevity, right? So it was life or death for them. Then moving into, got my master's at Appalachian State, worked directly with women's soccer and field hockey. Not only did I see the sports performance side and the sports science side, but I got to work with the athletic trainers, doing some return to play with ACL, even got to see lower leg compartment syndrome return to play, some wrist hand stuff as well. Now, where I'm at, or then Audrey Kell, as Jackson said, he took me in. I was an intern under him. He's the guru of return to performance, so I got to learn a lot. And now, last stop, I'm an assistant strength conditioning coach at Cannon School and the return to play coordinator. So we'll kind of talk about what, how, and why that looks like. So what's the purpose? Bridges the gap between injury clearance and performance training, right? Athlete gets that note from the doctor, says they're clear, they head to practice, all good. We know that they are not good, right? If they are not at we are asking them to perform at the level they were prior to injury, and they are nowhere near prepared for it. You got to think not only the body, but you got to think about mentally as well, right? There's a gap there. They've been isolated. They've been with their physical therapist. They haven't been with their team. They haven't even probably done movements of the same shapes and patterns the sport requires. So it also develops that relationship between the PTs and ATs, right? If we can get a collaborative effort with the PTs and ATs, it's just going to make it even better. We see a different side than doctors and some PTs will see, right? They see the one-dimensional. They're in the office. They see the injury. They see that, okay, MRI is good, X-ray is good, return to sport testing, very general tests says they're good, but we see everything. You probably know the academic load that your athlete's going through. You know what club teams are doing. You know what their sport requires. You know a lot more. Sometimes too much information because they like to overshare, but you know all of that. And so you are vital in a way that the PT or the doctor cannot give. Lastly, it should highlight your performance program, right? So preparing, protect, and instill that resiliency. I know all of us have that goal with our strength program, so it should also reflect in your return to performance program. So why? I got 3 main reasons here. First one, buy-in. If we offer a space for athletes to perform their rehab, especially if insurance will only cover a certain amount of sessions, parents are automatically going to get excited about that. Also, over reassuring parents that you have a whole team, ATs and strength coaches to back them up, they feel more safe than ever because you all have a goal of making sure the athlete's health and safety is good before they step on that field or court. Then longevity. So we all know there's a decline in youth sport participation. 2 main causes, injury and burnout. One thing I like to do with my return to performance athletes is educate them. So giving them the why of what they're doing and making sure that it's clear and they can know how to take care of their bodies after they leave me, right? So if they have knee pain later on in life, they know what to do. They know where to go from here because they had a plan that they went through and they were educated on why it matters. Lastly, coaches development. I think it's developed me as a coach a lot. I've had to kind of reevaluate myself, and I'm able to sit in a coaches meeting, in a programming meeting with Coach Powell and say, hey, there's some needs we need to meet here. whether it's a development issue, if like our JV girls basketball team, a lot more ankle sprains than we anticipated that year, we'll throw in a sprained ankle as an accessory, right? Just to mitigate that. And then also maybe we always compare like males and females just because the body is different. ACL, we're always trying to get ahead of that. So it just helps you reevaluate and check boxes that you may have not checked before. All right, I wanted to mention this because I think sometimes we get scared and back off a little bit. You should be confident in what your knowledge is, right? I am not afraid to ask questions to the PTs, ATs, and doctors. I put ego aside. I have a clear vision for this athlete, and that's to get them back on the field. So if I'm unsure about progressing, I'm like, I think we should regress of what I'm observing in the weight room or on the field, I'll ask about it. Or then if I'm seeing that they need to progress and they've been regressing too much and we're under training them, I'm going to reach out about it and we're going to have that collaborative effort. I've been fortunate enough to where I've had not a disagreement with a PT, and we've just been able to build onto that program. And then, like I said, your common goal is to get your athlete back on the court resilient prior to injury. So when I was thinking about kind of presenting this blueprint, I thought about what kind of model that looks like. And to me, it's more of a triad than it is a hierarchy, because all three of these do not over trump one another, right? This is all necessary to make a return to performance program what it is, right? To make it successful, to make sure that the athlete is doing their part and making sure you're doing your part as well. So first thing, communication with the athlete is probably the most important. I think educating them on their role in their own return to performance is very vital, right? Because they come to you, they think that you have a magical remedy. Like you're gonna make everything better, and that's your goal. You wanna be that person for them. But they also have to take responsibility into their own recovery. So whether that means nutrition, sleep, stress, trying to manage that stress, trying to manage training volume as well, you have to have that discussion with them. And then also asking the parents, making sure that they know that they need to have this role as well. Parents are the ones probably picking them up and taking them to the sessions with you. So you need to make sure that they are aware of what you are doing with them. ATs, I communicate with my ATs every day. We always talk back and forth, making sure we're updating each other on an athlete, where they are in as far as their phases of their injury. Sport coaches, I try and communicate to sport coaches of, hey, so-and-so needs less reps on those routes today. Like we're trying to ease them back in. He probably shouldn't be running full routes this point. And then PTs, doctors, I'm always emailing back and forth. PTs and doctors, they are more like collaborative than you think they are. And especially you're making their job easier. So they will always give you information. They always send me information back of testing and all of that. So I always put that into a spreadsheet. Support. So this is to get you kind of thinking about what your program has right now. And I'll kind of give examples of the things we have in our program and how I've used it. So equipment technology, timing gates, treadmill. I think most of us have timing gates. Even if you don't, getting them out to sprint is a great indicator of performance, right? We use treadmill, love treadmill. I promise Viliani isn't making me sponsor. But it's a way for me to get instantaneous feedback and for the athlete to get feedback. I'm also observing how they're running, making sure that everything is in line, making sure feet placement is good, head placement's good, making sure they are driving that knee. I make all my athletes do it. I don't care if you had an upper or lower limb injury. It's a great indicator of performance. Where you are at, it shows intent. Intent is what is going to mirror the sport. Then we're fortunate enough to have velocity-based training. So we have a sensor at every single rack. So for example, I had an athlete come back from a hamstring injury. So we were doing split squats. I'm able to see a discrepancy between each leg. We were trying to keep the speed above 0.75 and then loading up as we saw fit. wasn't much of a difference between legs, which was a good sign for me. So I checked a box for that one. And then plyomet, RSI, if you have a vertical jump mat, same thing. You can always do vertical jump to test lower body power, especially if they're coming back from a lower limb injury. RSI is great. I know plyomet has a setting so I can do 10-5 to check and see if, hey, is my phase 2 ankle return to performance program working? Did I create the ankle stiffness that I wanted to in that program? Team Builder, that has been the backbone of our program. Super easy to use. I can personalize. I'm able to go in and just modify an exercise so that they're able to still come in and lift with their team, stay in the same rotation, just maybe doing something else, whether I manipulate the tempo or if I manipulate the exercise totally. And then Hep2Go, it's home exercise program. This has been great. It's well worth it. It's $70 a year, and then the free version you can save 2 programs. It is a lot of our PTs that we reach out to use it as well, so it's just also easier to stay on the same page of using all the same language. All of our athletes knows what it looks like, and I'll show you an example of it later in the slide. But it's been great. You can customize, make your own program, choose exercises, all of that. And then BFR, we do not have BFR. I worked with it at App State for ACL rehab. I think it's a great tool, especially for prep. I would build upon that and just kind of use it. Like if an athlete has tendonitis, okay, we're going to use BFR for prep, and then we're going to move into bigger movements. I think it's really great in the early stages of ACL as well. I've had a few PTs reach out and ask if we've had it, which is a lot easier for them because then they can focus on something different in session. And then with me, they can do BFR and they know that's being taken care of. And then range of motion testing, we do not have that as well, but I know output has a parameter in it that has joint mobility and it can measure that in degrees. For me, our PTs send me numbers of where they are, like flexion and extension wise. So I kind of already have that, but I think if we had that in the weight room, that'd be a fun thing to play around with. We talked a little bit about this, the recovery, what does it look like? Sleep, nutrition, stress. I feel like we're all a broken record with that. We talk about it nonstop. Just keep telling them. I mean, hopefully they'll hear you one day, whether it's 5 years down the road or maybe tomorrow. Training volume. So wanted to go into a little bit of example with this. We had an athlete that had a pars fracture. I probably saw them twice in the weight room in the off season. Then we kind of sat down, tallied up how many workout sessions they were doing. This includes travel team, school team, and skill sessions. For a total of 30 days, they did 34 sessions. One of them was a lifting session. So you have to make sure you educate the athlete of this overtraining, making sure they are, especially at development wise, if they are not prepared to handle that volume, that amount of stress on the body, you have to make sure they hear you, because there's no reason a freshman should have a pars fracture, especially that young. And then how is the athlete feeling mentally? This is one I advocate for the most, probably. So that confidence versus hesitation. After an injury, they are rebuilding all those feedback loops, right? Brain sends a message to the muscles send it right back. They are rebuilding that whole system. If they have a non-contact ACL injury, right, they are going to second guess that break implant every single time. When they go in for that, especially when they're doing their sport, they are going to second guess that. That is just a greater chance of re-injury. So hesitation will always be the downfall. This is where I think we come in and we try and build that confidence, right? Build that confidence, try and get that decision making, because even if it's off by a millisecond, it can hurt them. So trying to build that confidence and making sure they are, ready for those big movements in their sport. And then isolation. Injury isolates you, right? We've all probably had an injury. Once upon a time, we were without our team. We were by ourselves. We probably felt most alone, acting like it only happens to you. They're doing everything on their own, PT, doctor, whatever it is, they're without their team. For me, how I can mitigate isolation is I require them to be in the weight room with their team twice a week. So all of our teams have weight room time twice a week. They have to be in there. I modify all of their programs, make sure that they are in the rotation so they're not missing out on anything. Right? If I can do that, I can at least control that. I can't control if they go to practice, if they go to games or whatnot, but at least I can take that piece and I can be an advocate for that. All right, adapt and reassess. So be patient. We all know, like within our program, it's not linear, right? There's going to be setbacks and you have to be prepared for them. Because if you're not patient, athlete's not going to be patient, you're both going to be frustrated. And then at that point, you just shouldn't do a return to performance program at all. You have to be adaptable, and then you have to make sure your athlete is going to be ready for that adaptation. So adaptation must reflect the stimulus, meaning whatever stimulus you give them, they are going to adapt to it. So you have to make sure you are giving them the right stimulus at the right time. All right. Then testing parameters. For me, I don't think there should be this general test of, hey, you're cleared, go out on that field. Everything that you used to do it. I don't think it works that way, right? I think I'm constantly evaluating them as they come to see me, making sure intent is there. The biggest thing is intent. Are they giving me the best intent in the weight room? Are they giving me out on the speed for speed sessions? Are they helping out their teammates? Are they getting involved with the teams? Are they going to their coach, learning plays, learning routes? Are they staying involved with the team? That's one thing that I think the doctor can miss. Okay, they think you're all good, quad, hamstring ratio strength, it's great, but up here, it's always up here. And then lastly, you got to keep data, program notes, and then all the notes that you get from your PTs. That helps you reevaluate and go back and assess your program. Like I said before, I can look back because I have all my notes. Am I seeing a common injury between sports, maybe development-wise, freshmen compared to my seniors? I'm probably going to see a lot more issues in freshman-wise just because we are building from the ground up with them. So we'll talk about building your protocol. So what will your standards, expectations be, how your communication will be done, and how will you organize your program? So I'll talk a little bit about how I communicate. So as soon as the athlete sees the ATs, right, that's my standard. You have to go see the ATs before you see me. In our scope of practice, we cannot diagnose or give a referral. So they go see them, AT communicates with me, we kind of figure out communication plan through that. Route 1, they need to go see a doctor, and then they'll go to a PT. I try and get their PT information as soon as possible, and most of our athletes are aware, and our ATs let them know, hey, you're going to see a PT, make sure you contact Coach Kenzie. So we'll give an example. So this is my protocol that I have written down. We've presented this at fall coaches meeting, fall parents meeting. So we're really trying to get the word out here of what our standards and expectations are and what it looks like. Especially for parents, they understand there is another resource out there to back up, especially if their child goes through an injury. So I talk about what it is, what's my purpose, and then my first steps. These are my standards. Like I said, go to your AT first, and then their expectation for me is I have to be able to modify and come up with a plan, which I try and get on it as soon as possible, and then I try and communicate back out to sport coaches, athletes, and then I update like PTs, hey, this is what we're going to work on. This is good. Like, is this what kind of complements what you're doing in your sessions as well? The next step, if the athlete requires a little bit more one-on-one time, we try and schedule a time for that. So we have office hours, lunch drops, as well as including their team's weight room time. During after school, during their team's weight room time, we might have lack of personnel. So I have to have eyes everywhere. So it may require a little bit one-on-one time, depending on the severity of the injury, obviously. And then one of my standards is consistency is key. If I give you at-home exercises, you don't do them, and you come to me and say, hey, it still hurts. Did you do your exercises? No, it just still hurts. I can't help you. I don't have a magical spell. I'm trying to help you, and you're already way behind than what my plan is. So if you're not going to get up with my plan, then we're not going to do this. Because most likely, either they're trying to get out of the sport, get out of practice, whatever it is, and I'm not advocating for that. I'm here to help, especially when I have athletes who come and see me every single day. I know where to pour my time into. And I think that's one thing you have to realize when you build this kind of program is you have to understand where to pour your time in, because it is exhausting, but the athletes that see you every day want to get better. You know who they are. And then obviously keep repeating, controlling the other 22 hours, sleep, nutrition, stress, all of that. This is how I'm organized. This is what my process is. So phase one, we used to do it to where I had all the phase one exercises printed out. So it was all from hep to go. Athlete would have to come see me, and then they would go to the athletic trainer, and then it was just too many obstacles, too many roadblocks. So I sat down and I was like, why don't we put our phase one exercises in the AT room? That way it mitigates some of that just overlap and gives a little bit more hands-on for the ATs. So in the AT room, we have folders. I have created exercise plans probably for just about every injury. AC sprain, I have shoulder instability, I have big toe strengthening, I have hamstring strain, I have a lot, hip and groin. So it's all in there. When the athlete sees the AT first, the AT is able to give them those exercises. So it cuts a middleman out. Then AT will communicate with me, this is where they're at, this is what they've been doing. I'm going to them and I'm going to ask them for updates. How are you feeling? How are you? And I'm going to watch them and observe them during lift, see how they're adjusting well to it. See if that achievement of range of motion is going the way I think it's going. Then load introduction. So this is where I kind of go more into eccentric control, especially control of the body weight. And then phase 3 and 4, like I said, it's kind of intertwined. I'm constantly evaluating. Thankfully, we have the VBTs at every single rack, so I'm able to just keep, testing out, seeing, pushing, trying to give that stimulus where it needs to be given. And then, we'll talk about how what my spreadsheet looks like and how I organize all my notes too in a second. So I want to touch on tissue healing as well. This is like a general model of my thought process. So when they come back from surgery, so say shoulder labrum tear, they're going to do passive range of motion, right? Probably going to be immobilized for a bit post-surgery, but then they're going to do object. Therapist is probably going to move them, and then they'll probably do pendulums, let gravity do its thing. This is where I like to come in, fibroplastic repair. So they're achieving that active range of motion, right? This is where the tissue starts to repair itself, and I want to get in there and make sure it's getting the stimulus it needs. And then remodeling, this is where collagen is really high, so that's when I begin my eccentrics, trying to control that tissue's integrity. So this is what hep to go looks like. It's dummy proof. They have a picture, they have a description of the picture, they have the title, I'm able to say the sets, reps, how many times a week to do it. I can do how many times a day to do it. It has been a great extension. This is what our phase 1 ankle looks like. So say like a grade 1, grade 2 ankle sprain. This is what they would be doing. And then this is my phase 2. So like I said before, going into that eccentric loading, and then I microdose some isometrics to it as well. This is where I'm trying to get ankle stiffness back in the ankle joint. And then, like I said, I can use RSI 10.5 to see if my phase 2 achieved what I was trying to stimulate. Finishing off with some dynamic movement at the end. Actually, I'll play that again. Which his dorsiflexion is god awful, but we're still working on it. All right, moving on. So that's example of like my phase 1, phase 2 ankle. Now we're gonna kind of move gear to more of a injury that was a bit more severe. So this is what my spreadsheet looks like. I know it looks like a mess. I throw all my notes in it. Coach Powell sometimes looks at me crazy just because everything's thrown in it. But I promise I have everything in it. So this top half was a post-shoulder labrum repair. As you can see, it come here. Last March, he was fully cleared. Then this football season, we were not so lucky. He had AC sprain in the other shoulder, and then in the shoulder, he had his labrum repair on, shoulder dislocation. So we had to start all over. Like I said, there are setbacks. Be patient, and try and be that rock for your athlete, especially when all he wanted to do was get back to play football. And it was a very heartbreaking end because this is his last year. So all of my notes, this is when we started this fall. And then I'm going to show you an example of what we're doing now. We really built it up. So this is before Thanksgiving break. This is our prep. He's cleared for most things. Pull-ups, we still aren't there yet. But I start with rhythmic stabilization with this stick, and then we do wall ball. And then we'll go into diagonal band pull aparts for some dynamic stability. And then we'll do internal, external rotation, single arm and double arm. Just trying to strengthen the rotator cuff muscles back up, whole capsule of the shoulder joint. And then prone abduction is when we start, that's when we kind of moved on from that. Now I'm trying to microdose some of this fast concentric movement with med ball work, especially he plays baseball. So I'm trying to move closer to the shapes and patterns of that. So I'll play it one more time. But this is an athlete that sees me every single day, you know. Lifts more up to 4 days a week. All right. Now I'll go into, right now we have overhead press as one of our main movements for upper body. Just want to give an example. He's looking at our VBT, so it's sending instantaneous feedback telling him how fast he is going. I promise he does do weight. This was just, I want to show the tempo first. But so we started with eccentric control before Thanksgiving break. That was, and then we moved to ISO drops. So here the purpose of my ISO is to allow the motor unit synchronization and then to pop out of the movement. So we will be doing this until Christmas break because he is very eager just to be normal and do the same thing with his teammates. but we also do bench press. I have him doing the same thing. We moved from floor press to mitigate the range of motion, and then we moved to blocks on his chest, and then we did eccentric as well, and now we're doing iso drops. Another example of a severe injury, this is ACL and lateral meniscus repair. It has been a year. It should not take this long, but there was a lot of setbacks that put us behind. 2 steroid injections. So whenever steroid injections happen, you jump on that, right? They feel so good, feel great. You're going to jump on that. You're going to train them as hard as you can. So kind of where we went, I had modifications that she had so she could be with her team. And then her PT and I talked, needed to work on her plyometrics. So she had a plyo day with me. And then moving into return to sport testing, her functional testing wasn't where we wanted to be, especially quad to hamstring strength ratio. So we just kept working, kept loading, trying to get into those big shapes and patterns. And now we're at return to sport testing progression to where before Thanksgiving break, she was doing controlled 1v1. To me, when I thought of that controlled 1v1, I wanted to give her a lateral speed program with a reactive component, because as you can see, the next progression was 2v2 to 5v5. So preparing her for that lateral reactive, especially in the game of basketball, was my main goal. So this is what her lateral speed program is. We do feet and ankle prep, and then we'll go into some dynamic flexibility. And this was a program I gave to her over Thanksgiving break to do. She was seeing a skills coach because she's able to do some basketball skill work. So I gave this to her to work on with him as well. Some prep for her getting exposed to some shin angles. And then going into vector broad jumps. I'm hoping to progress her from here of moving into a double, leaving double leg, landing single leg, or vice versa. But it's just trying to get her hips facing to where she wants to go. Just trying to get some rhythm into this one. Separation of hip and torso. And then this, in a perfect world, I would be with her and she would go on my whistle for that reactive component. But still getting that stimulus of moving laterally and then changing hip position. Lateral bounds, get our plyometric in. And then this is where I want to work on tracking. I know that was really short, but crossover run to burst. I'm telling her to picture the pass flying by and you're going, you know where it's going. Working on her break plant separate. So her injury was actually contact ACL. Girl stepped on her foot as she was turning out. So still trying to get her confident in that deceleration. Just making sure she's confident wherever she places her feet. So we worked on break plant separate and into a wide base crossover as well, decelerating every single time. The amount, if I can give her so many reps of that break plant separate, I'm hoping muscle memory will do its job and she'll be able to put that out onto the court. All right, last thing I want to do to wrap this kind of all up, kinetic chain theory. I want you to kind of think of the human body as a chain reaction and not just a chain, right? It's not a sequence. You have an ankle sprain. You could probably name so many things that's going to overcompensate for that, right? Your knee, your hip, your back, your low back, you're going to feel low back pain, just depending on how your gait is affected. right? So I always like to think bigger. Like it's great to isolate, yes. For example, patellar tendonitis. You hear athletes say, "Oh, I have knee pain." Yes, you can target the VMO all day long, but just isolating the VMO isn't going to translate to that sport, especially what the sport demands. Sport is not kind, right? They are chaotic. You have to prepare them for the chaos. So you got to think of, all right, knee pain, repetitive jumping, right? You always hear that with patellar tendonitis. So you got to work on contractions of both hamstrings and quad surrounding that joint, especially in sport. It's not, the VMO isn't the only thing working there, right? It's everything else is working as a system. There's an integration part, and you need to make sure you're doing integration right in your return to performance program. I want to say my thank yous, of course. Thank you to Coach Powell, who has allowed me to grow in this position and trusting me with our return to performance program. Thank you to Kyle Jaksic and Travis Webb. They were the first return to play coordinators, former return to play coordinators, so I got to kind of just build on top of what they already laid the foundation for. Our Canon AT, Haley Goldman, she's a rock. I hope I make her job easier as she makes mine a lot easier. And then lastly, Dr. Amy Mirswa, fantastic PT that I've gotten very close with and got to work with. She takes the time, she sees a lot of our athletes, and she'll communicate with me about everything. Contact information. I no way think I'm an expert on return to performance, but I have a high passion for it. So anytime you want to talk shop, more than happy to share my programs too. More of my phase 1, my phase 2 programs. Don't mind at all. So, yeah. Oh, any questions?
I had a quick question.
What's up?
The athletes that you work with, are they injuries that they have? Are they from club off campus that you take care of them, or are these canon athletes that it's scholastic sports that got injured, or is it a mixture?
So it's kind of a mixture. So they are my canon athletes, but like I have one, she injured her ankle during club soccer, but she's still a canon athlete, and I know she's doing canon school soccer, so I help her. There's also an instance where I had another canon student who doesn't participate in a sport at canon, but is a student at canon, but does dance and had also ankle issues. So I also helped her. I'm really, if you go to canon, I'm going to be willing. Yeah.
And one more. On
Yep.
On the regressions that you talked about, are you looking at? You have baseline measurements for some of these kids through canon, or do some of their clubs have baseline measures that help you create the start of your protocols, or you fade your magic wand and try to put that into play? Let's say in a canon K through 12 situation.
So they should all have like baseline numbers, like we do. Vertical jump would be like a baseline number, and then we try and get shred mill numbers baseline. So I have that to work with, but most of the time I honestly use as like my coaches. I've seen you in the past, and I've seen how you've grown, and then you moving like this is not where we should be right now.